All right, so I'm gonna start with my pre-procedural steps. So I've already checked the patient's chart, I've gathered my supplies, I have my stethoscope, my reflex hammer, and my gait belt. I am going to wash my hands and introduce myself. Hi, my name is Brittany, I'll be your nurse today. Can you tell me your name and date of birth? Perfect. Okay, so I've introduced myself. My next step would be to provide the patient with privacy, so close the door. I'm gonna explain the procedure. Just wanted to let you know we will be doing a few different assessments. Takes about 15 to 20 minutes. Do you have any questions before we get started? Perfect. All right, well, I'm gonna raise the patient's bed and I'm gonna go ahead and do the respiratory assessment first. So I'm going to start by identifying the lobes. On the anterior side, I have the right upper lobe, which ends at the 5th rib. And then I have the right middle lobe, which ends at the 6th rib. And then the right lower lobe starts at the right oblique fissure. On the left side, the left upper lobe ends at the left oblique fissure, and then the left lower lobe ends at the 6th rib. On the posterior side, the left and right upper lobes end at T3. The lower lobes end on expiration at T10, and then on inspiration T12. Okay, so I'm going to start my assessment by inspecting. I'm going to inspect the patient for any distress or nasoflaring. That would be a sign of respiratory distress. I'm looking at the AP diameter. I'm making sure it's a 1:2 ratio for anterior posterior diameter and transverse diameter. I'm looking at the anterior thorax. I'm making sure that no accessory muscles are being used to aid in breathing. And then I'm looking at the posterior side for position of the spine and any deformities. It would also be a sign of respiratory distress if there were retractions between the intercostal spaces. Okay. So now I'm going to palpate. I'm going to be feeling for lumps, masses, and tenderness. On the posterior side of the chest, I would place my hands under the scapula and I would pinch in the spine area. And I would want to have the patient breathe in and out, take a deep breath in and then out. And I would want to see my thumbs move symmetrically. If one thumb moved and the other didn't, that would be a sign of respiratory distress. I can also feel for tactile firmitis. So I would place my hands on the patient's back and have them say 99, and I would be feeling for the vibrations. So place my hand 99, 99, 99, 99, 99. And then I should feel those same vibrations going in that zigzag shape. I'm going to percuss. The 5 anterior spots that I will percuss start at the top of the lungs and then move down in a zigzag line. So I would do, trying to see if you can, so starting here, 1, 1, 2, 2, 3, 3, and then down to 5. Sometimes it can be hard to feel that 5th area because of breast tissue. And then on the posterior side, we have 9 spots. So same thing, doing that all the way down. And then the 8th and 9th spots are kind of along the side. So if this is the patient's back, they would kind of be on the sides. Okay, and then I'm going to start auscultation. I'm not gonna actually put this on, but we should be using the diaphragm side of the stethoscope when we do these. We're listening for pitch, amplitude, duration, quality, and then what other one am I forgetting? And the normal location of each breath sound. Bronchial sounds can be heard in the trachea, and then the Oh, the bronchial sounds are hollow and high-pitched. And then the bronchiovesicular can be heard in the second and third intercostal spaces next to the sternum. And then the vesicular sounds occur within the lobes of the lungs. So that is it for respiratory. So I can go ahead and move on to cardiac. So I'm first going to locate the heart. It's mostly on the left side of the chest with the precordium region. That starts at the first rib and then ends at the fifth intercostal space, which is where the apex is. During auscultation, I'm listening for the S1 sounds, which are the AV valves closing, and then the S2 sounds are the SL valves closing. Then I'm going to assess the 5 areas, which on the right side, the only one on the right side is the aortic. That's at the second intercostal space. Next is pulmonic, second intercostal space. Erb's point, third intercostal space. Tricuspid, I think, would be next. That's at the fourth. And then mitral. So the mitral valve is heard at the fifth intercostal space. I remember that by ape to man. So try to go through that. I'm going to palpate the pulses. So I'm going to assess the temporal, the carotid, the apical. Sometimes to feel the apical pulse, you'll have to lift the breast up, and you can also hear it there too. We're going to do brachial, and then radial and ulnar. Then we have on our legs, popliteal, which is under the knee, and then femoral, which is in your groin area. And then we have posterior tibial, which is the inside of your ankle, and then pedal, which is on top of your foot. So I'm assessing those. I'm also doing an edema assessment, so I'm pressing into the patient's skin, and I will be feeling or assessing to see if the patient's swelling or skin is dimpled in for edema and swelling. So when I do that, this patient, I'm scoring this patient at 0+, no edema is present, so no swelling is present. I'm also assessing the capillary refill in the fingernails and the toenails, so pushing those down, making sure that the color comes back up pretty easily. And then I'm feeling the patient, patient is warm to touch. So no areas of patient are cold, resulting in no blood flow to that area. Next I'm going, neurovascular. So the 5 Ps, pallor, pulse, pain, paresthesia, and paralysis. So patient presents with tan color spread throughout the body, pulse. Patient's pulses were strong through multiple areas. Patient doesn't exhibit any pain during assessment. Patient is able to move extremities with no tenderness, no pain. And then patient responds to, you could do like a light touch or like a 2-point threshold, something like that. Next up is the abdominal assessment. So I'm going to lay the patient in a supine position. I'm not sure if you can see that. I'll put it on the pillow. So, scoot it back a little. There we go. So I'm not going to percuss or palpate yet because I don't want to create any false vowel sounds. So my first thing that I'm going to do is just inspect the patient. So inspect the abdomen. I'm looking for scars, hernias, bruising, lesions, rashes, moles, stretch marks, those types of things. I'm going to do my auscultation. That's one of the first things that I'll do. So I'm gonna start in the right lower quadrant, so down here. I'm sure you can see that. That is where the ileocecal makes the most vowel sounds. So it's the first place that I will start. I can expect to hear in between 5 to 30 vowel sounds. So anything less than 5 would be hypo. If you don't hear any sounds, that's absent sound. That would be an absent vowel sound. If you hear more than 30, that is going to be your hyper vowel sounds. So normal is in between 5 and 30. So I'm going to start in my right lower quadrant. What's there? That is where my cecum and appendix is located. My right upper, that is where my gallbladder and liver is located. And then I'm going to move to the left upper. That is where my spleen and stomach is located. And then the left lower would be where my sigmoid and part of my descending colon are located. So now that I have those identified, I'm going to percuss in each quadrant. So I should be tapping 2 to 3 spots like this on my patient in each quadrant. So right lower, 2 to 3 percusses. Right upper, 2 to 3 percusses. And I'm listening for tympany or dullness sounds. So the dullness is going to be where the organ, like where the dense organs are located. But I should be hearing tympany within those. I need to lightly palpate in each quadrant. I'm feeling for rigidity, masses, tenderness, and watching the patient for any muscle guarding. The kidneys. I forgot the kidneys. So I'm going to turn the patient over, or actually I'm just going to have the patient sit up for me, and then I'm going to place my hand right where the kidneys would be, and I'm going to ball my other hand in a fist and kind of punch it or knock my hand. I don't want to do it too hard to hurt the patient, but I need to do it hard enough for the patient to feel it. And if they jump or if they are like in pain, that's when you know that there might be something wrong with their kidneys, like a kidney infection or something. Let's move on to musculoskeletal system. So I would need a gait belt if I did not trust the patient to stand on their own or if they were at risk of falling. So if you're not sure, definitely use that. I'm going to have the patient stand up and walk, and I'm going to watch the patient's gait. So their arms should be swaying, their head should be facing forward. I'm looking for like any limps or if their feet are shuffling. I'm looking at their trunk position, their spine position while they're walking. I'm looking at their posture for hunchback or sway back or curvature of the spine. So hunchback is the kyphosis, and then sway back is lordosis. Curvature of the spine is scoliosis. So I'm inspecting the hips, the scapula, and the spine. And when I assess these things, I'm going to have the patient stand up. And then I'm going to place my hands along their back. And then I'm going to have them bend over. So when I do this, I'm feeling for all of those things to make sure that there's no popping or cracking or anything like that. And then I'm going to assess the patient's range of motion by having them do 5 reps on their own and then 5 reps with added resistance. So when I do this, again, I'm listening for popping, tenderness, pain, things like that. So for each joint's range of motion, I'm going to watch them. So I'm also going to feel for them. I'm feeling for heat, swelling, and tenderness. And then I guess we need to do each joint. So shoulder joint moves in a circumduction movement, so it should be able to do this. So the patient can do this, and then I will just feel and palpate. Do I hear any cracking? Nope. Okay, excuse me. I'm going to assess the neck, so the neck should rotate like this. Patient can do it and then palpate while they do it. No pain, no tenderness, no cracking. And then the patient's arm, gonna have them extend and flex, just like this. You can feel right here for any cracking and also feel right here. Gonna do the same for patients' legs at the hips and at their knees. So again, have them flex, extend, and then feel for popping, cracking, tenderness, and pain. Okay. And then I also assess the patient's muscle tone and strength on a 5 to 0 scale. So I don't know if I said this either, but oh no, I did say it. The muscle strength on a scale of 5 to 0. 5 being full muscle strength. So that concludes all of my assessments. So I'm going to do my post-procedural steps. So I'm going to raise the bed or lower the bed back to where it was. I'm going to ask the patient, do you have any additional needs? You could just say, is there anything else you need from me? No? Awesome. The doctor should be in with you in just a little bit. Here's your call light. If you need anything, let me know. Okay. Once we do that, I'm going to dispose of my PPE, going to clean my stethoscope, wash my hands, and then I'm going to do all of my documentation. That concludes all of the assessments for today. Yeah, thanks.